I've been given the challenge of talking about the evidence base around health and people with learning disabilities in 20 minutes. Yeah. Now I could probably keep you here and award you a complete module for attendance in relation to the health needs and evidence base, because it is a growing area. So I've had to be selective in what I'm going to present this morning. So please take it in that context. And I've also, there's a couple of areas where I'm not going to touch on because things like health checks and that are going to be picked up on during the day anyway. So, start with some headlines. I suppose the good news to start off with is that overall life expectancy for people with learning disabilities is increasing. That means that particularly there's two groups of people where we're seeing a lot of increase. One is that perhaps younger people, children, young people with very complex needs are now living much longer and living into adulthood. But that actually presents us with a new challenge perhaps of how do we best meet their needs. But we're also, like the rest of the population, we're seeing an ageing population, and that brings, again, additional health needs. But even though overall life expectancy is increasing, we know that people with learning disabilities are still at risk of premature and avoidable deaths, and I'll give you some research around that. Patterns of disease and illness can also vary from the general population. So people with learning disabilities have the same health problems as everybody else, but sometimes they occur perhaps with a different sort of prevalence and incidence. So if you take something like patterns of cancer, the patterns of cancer in people with learning disabilities are probably different in terms of the major causes to the rest of the population. And the other thing is that whilst we know that there are some, if you want, biological causes, so sometimes people will have a specific syndrome or condition which brings with it an additional risk of particular health needs. A lot of the causes of health inequalities for people with learning disabilities are down to other factors, and it's saying there things like health, well-being, are affected by, it's not just even healthcare provision, it's social care provision, it's around sort of economic provision, things like that. And that report there, Rickard and Donkin, that was a report which was done by the Health Inequalities Unit at University College London. So what are some of the causes of health inequalities? Now Eric Emerson and his team have done quite a lot of work over a number of years, and they've done a number of reviews and published them, and they sort of tend to put them into these areas. One is this increased exposure to the social determinants of health. So people with learning disabilities being at higher risk of poverty, poor housing, lack of education, things like that, all of which we know generally impact negatively on people's health. There is the increased risk associated with specific genetic and biological causes. So, for example, people with Down syndrome may be at increased risk of certain health conditions such as early onset dementia, things like sort of cardiac problems. Doesn't mean to say everybody with Down syndrome has those particular conditions, but there's an increased risk. Communication difficulties and reduced health literacy. Whenever I talk about this, I always sort of put a caveat in because we talk about people with learning disabilities having communication problems, and that's one of the issues in the context of healthcare. I'd like to us all, particularly those of us that are working in healthcare, to think actually healthcare professionals have got communication difficulties. Yeah? We're not very good at communicating in ways that people understand sometimes. There's personal health risks and behaviours. In some studies, we've got a growing awareness of things like drug and alcohol misuse impacting on people with learning disabilities, obesity, low exercise, things like that. And then the deficiencies in access to and quality of healthcare, which are some of the issues perhaps which Jane has also been raising. So some of these studies, and again, I've picked out a few here. I've had to be selective, but this is a study, fairly recent one, 2016. What they did was they took the data from 343 general practices, and you've got the numbers there. They matched people with learning disabilities with what they call controls, so people who were a similar age, gender, things like that. And what they found when they looked at this was that overall, adults with learning disabilities have got higher mortality rates, so they were dying more often, even after adjustment for things like comorbidities, so other healthcare problems, things like smoking and deprivation. So there's something else going on here. The social factors do impact, but there's something else. It was higher mortality rates amongst people with Down syndrome and epilepsy, sometimes for some of the reasons which I've already talked about. And I think this last one is an important one. 37% of the deaths of people with learning disabilities were classified as being amenable to healthcare intervention, compared with 22.5% of the general population. So even in terms of what is avoidable, what is preventable, what is treatable, there's disparities. And not surprisingly, they come to that conclusion, that there's a need to improve access to and quality of health care amongst people with intellectual disabilities. Apologise because that's a direct quote. A lot of the literature switches between intellectual disabilities and learning disabilities, but take those to mean the same thing. So what we do have in England at the moment is a programme known as the LEADER programme, and some of you will be aware of that. We've had, I suppose, a series of things. Jane highlighted the 74 deaths and counting. We had the Michaels report. We had the confidential inquiry back in 2013. And then as a result of a whole sort of growing body of evidence, we've now got the LEADER programme, which is being held, well, it's coordinated by University of Bristol, but it's looking across England. And they're reviewing the deaths of people with learning disabilities who are aged 4 and above. Now in this period that they've been operating, so July 2016 to December 2018, there were 4,302 what they called in-scope deaths that were reported to the team. By December last year, reviews have been completed for 25% of those. I can't go into the review sort of process, but at the end I've given you the details for the LEADER website. If you look on there, it goes through the review process, but it is quite a comprehensive one with people looking, having an initial scan, if there are things, there's a full review, and et cetera, et cetera. So some of the things that they're finding from that, and what I would say is that this 2018, they produce annual reports, which again are on their website, so easy access to look at those. What they found was that the median age of death was 59 for people with learning disabilities. That was 60 for males and 50 for females. But what's quite interesting is when you compare that to the general population, there's actually a disparity, a difference of 23 years for men and 27 for women. Interesting, because in the general population, of course, women would probably be living longer than men, so there's something going on here as well, specifically around women with learning disabilities. There's differences in terms of where people die. So the proportion of people with learning disabilities dying in hospital was 62%, for the general population 46%. What I will say is what they're flagging in their report, but also more broadly, is this sort of concern about actually coding when we come to have death certificates. For those of you who aren't aware, you have the sort of the primary cause of death, and then you have various what we call underlying causes or contributing factors. Bizarrely, sometimes you get people putting down things like learning disability as a cause of death. Yeah. No, it's, it may have been a contributing factor in as much as other people didn't respond appropriately, but actually that's not. So there's a lot of things, and things like, it's difficult because obviously learning disability will not always be identified, and perhaps shouldn't be identified on a death certificate. So some of the figures which we have, it's quite difficult to get an accurate picture of what's going on. But when they looked at the cause of death that was recorded, these were what they had. Pneumonia and aspiration pneumonia at the top, and that's fairly consistent. Respiratory health, respiratory problems is usually listed as the major cause of death of people with learning disabilities. Sepsis, 7%. Dementia, 6%, ischemic heart disease, and epilepsy. Those findings are fairly consistent. If you look through the body of literature, the research which is coming through, it's a similar pattern. What they also find is things like variation in the time of things like pneumonia and aspiration pneumonia, where people are now beginning to perhaps be much more conscious about trying to encourage people with learning disabilities to have flu vaccines, for example. They did identify some good practice, so strong, effective interagency working, obviously, which was helping. Good person-centred care. They identified some good examples around end-of-life care. And what underpinned a lot of that good practice is this ability and capacity to make reasonable adjustments. So adapting the way in which we do things in order to get better access for everybody. So with the poor practice, delays in diagnosing and treating illness. And there's a whole range of reasons which contribute to that, which I can't go into because of time at the moment, but if people want to talk to me about it during the day, I'm happy to, because there's lots of things that can go wrong between actually somebody identifying or the fact that perhaps somebody has a health need to people actually getting treatment. And then there's also, they found poor practice in relation to the quality of health and social care in relation to how that contributed to people's health and ultimately to their death. One of the other issues which is quite common for people with learning disabilities is what we call multimorbidity. I mean, this tends to happen as people age anyway, but it's quite, the sort of multimorbidity tends to kick in perhaps at an earlier age for people with a learning disability. So one study, which I haven't quoted here, but sort of suggests that sometimes what you see in terms of multimorbidity and frailty in the general population at 75, you might sometimes see in people with a learning disability at 55. So it's happening earlier. And multimorbidity is just where you've got 2 or more chronic conditions as well as having a learning disability. So you might have epilepsy, and you might also develop diabetes, for example. Or you might have diabetes and you also develop renal problems and hypertension, things like that. What this study did, and it's a very recent one, looked at 920 adults who were included in a screening study for diabetes. And what they found was that of those 920 people, 61.2% had actually got some kind of multimorbidity. They found that it was perhaps independently associated, so higher risk if you were female or you had severe profound learning disabilities. And also those who were physically inactive or sedentary were more likely to have multimorbidity. That's important because if you look at other research, we know that people with a learning disability generally have lower rates of exercise, lower rates of sort of access to good nutrition, things like that. This is, they pulled it out in terms of the number of what they call QOF conditions. These are obviously the ones which GPs are sort of paid to pay particular attention to. So there's a long list, but things like hypertension, diabetes. And they compared people with learning disabilities, again, with the general population. So the number of people with no sort of QOF conditions is 42.8% in people with learning disabilities, but in the control group of people without learning disabilities, there's a 20% variation there. And if you look all the way through, the number of chronic conditions within people with learning disabilities is higher. And if you look at some sort of studies, you're talking sometimes of people with like 12, 13 sort of different conditions. And of course, the problem with that is that, some of you probably recognize this. You have one condition and you get one set of medication for that, and then you get another one and they give you another medication for that, which doesn't always agree with the first medication you had, but sometimes it's different doctors dealing with those. And so you can see how there's the potential for it to become very, very difficult to coordinate and to have a look exactly what's going on. I know one of the workshops later is going to look at constipation. So I just pulled out this one. When they looked at whether there was ever a record of constipation on people's notes, for people with learning disabilities, almost a quarter had that. It was 8% for people without. So you can see lots of variation. And there could be lots of reasons for that. Again, lack of exercise, some of the medication which people are taking. But there are disparities all the way through. Not surprisingly here, they sort of say, people with learning disabilities generally have got higher levels of chronic disease and they make greater use of primary care. And what they're arguing is that actually if we get much better at management of long-term conditions, they call out particularly epilepsy and mental illness, but I think it's a whole range. Actually, that will help to address some of these greater needs. And so, perhaps unsurprisingly, continuity of care and longer appointment times are areas that we could be working on for that, which will help. And those obviously are reasonable adjustments. So just to pull this together, this isn't from a particular study, this is just some of the themes which I pulled out from a lot of the research. Things which you get are lack of recognition of health needs. Yeah, it's quite difficult sometimes. You think about it, we have a healthcare system which relies on us being able to say, this is happening, that's happening, something else is happening. For a lot of people with learning disabilities, they may not have the vocabulary, they may not recognise it. We don't always recognise when something's wrong, so, it's difficult. Other people may not recognise that there's a need to take action. There's lower uptake of things like screening, so cervical screening, mammography, things like that. Jane's already mentioned diagnostic overshadowing. When somebody's, perhaps their behaviour changes, people say, oh, that's because they have a learning disability or they've got challenging behaviour or something like that, where actually that's somebody communicating that something is wrong, it's a health need and we need to respond to that. Communication barriers, as I said, sometimes people with a learning disability may have difficulty with expressing the fact that they feel unwell or something is happening. Other people may also have a communication barrier in terms of they don't listen, or they just listen to what is said rather than listening with their eyes as well. Failure to make reasonable adjustments, and the lack of education perhaps that's provided for healthcare staff. We're getting better at that, but it's still possible that people go through, for example, nurse training, medical training with very minimal exposure to or education around the health needs of people with a learning disability. So then perhaps it's unsurprising that people aren't alert to things like, well, actually if we have somebody with who has Down syndrome, maybe we should be looking for this because we know there's a higher risk of that. So people, things like communication, a lot of what we find with nurses when they go on placements, and some of our students who aren't learning disability nurses go on placement with people with learning disability, initially it's a lot of, oh, I don't know what I'm going to do if they don't understand me, I don't understand them. But actually once people start to interact, people's confidence and competence grows. So we need to think about how we do that. And there's just the last one, I think, which is quite important. This lack of awareness and understanding of legal requirements. We're still getting reports of people not understanding the Mental Capacity Act, asking other people to sign consent forms, sort of saying, making assumptions around, or because somebody has a learning disability, they can't do this. So I think there's still a need for us to be really sort of working on that area, because without that, again, people are going to have limited access to some of the healthcare they need. So that is a very, very quick and potted version. What I've got there, and I'm happy for this to be circulated, I've given the sort of the website there for LEADER, and I've also got the Institute of Health Equity report. So if people want further information, it's there. I am around all day, and I'm more than happy to fill in some of the gaps if people want me to. So I haven't got my total sort of stop card. I got my 5-minute one from Andrew, I got my stop one, so I'm stopping now.